Hi folks, this is John Adamson, the Rehab and Documentation Guru, making another video on this day after Thanksgiving. So this is related to another feed that I had, commentary, and the point was made by a therapist, I believe a therapist, that an assistant by themselves could not make a determination of whether a patient should be in group or not. And I think this therapist may have misunderstood my point. So, you have a patient who has on their orders group therapy. That care plan was established by the therapist, signed by the doctor. It is now orders. And the expectation of a therapist, if they put group on the care plan, is that group is a necessary component of the patient's recovery. Therefore, it follows that an assistant should follow group. And I think that's basically what the therapist was getting at, and I would agree to that. However, my point was not that. My previous video was on the RAI manual, in that the therapist and the assistant should be telling the director of rehab or whoever does the patient schedules for the therapist who belongs on group and who does not. They make that determination, not the director of rehab. So it's out of the director of rehab's hands. That was my point. Now, let me touch base on this because I think there's a more nuanced answer to this whole question of whether an assistant should make the call about whether a patient should be on group or not. And the answer is, I believe they should. Now, here's one thing to think about. An assistant has a license, and they went to school to do various treatments and assessments. And they have the ability within the care plan developed by the therapist to make some adjustments based on the clinical presentation. That's what makes them a professional. If I expect an assistant to just rote follow a program that I developed, they're little more than a technician. They're not a skilled practitioner, and if a patient is anything other than clinically stable, I probably don't want them seeing that patient. They don't have the skill or knowledge to do it. But let's face it, we have a lot of assistants who, because of their training and their knowledge and their expertise and their licensure, who see very complex patients. And so they have to make some decisions on the fly, irrespective of the therapist being there. Now, obviously, there are some state practice acts that limit what the assistants can do. There are some third-party payers that don't even allow assistants to see their patients. And so they have restrictions that go above the law. Now, my point was based on the RAI manual, which is the governing document over SNF and long-term care. That is, the governing document has legal authority in those settings. And so it's perhaps less stringent than some state practice acts. So that's what I was basing my comments on. So I fully expect an assistant to make the determination of whether a patient can't be on a group for a particular day. Here's the scenario I brought up. You have a patient who is supposed to be part of a group. The assistant is going to be doing the group. The patient comes to the group, but the assistant notes that this physical therapist ordered group was, the patient was noted to be diaphoretic. They're a little pale, and they're saying they're feeling a little bit weak. I'm not going to put them in the group that day. So let's say I'm the assistant. I send them back to the nurse, and I say, nurse, this patient I know has a history of diabetes, and anyway, they're sweaty, and they seem, kind of punky. Do you mind checking their sugar? And it turns out the patient is hypoglycemic. So I exclude them from the group. I proceed to do my group because I've got all those other patients waiting for me. They deserve a group. They should get it. That patient that went back to the nurse's station gets, a small dose of like 15 grams or more of carbohydrates mixed with protein. Sugars rebound. They feel a lot better. They're doing fine. I go back to that patient later on and I give them individual care in that case because they still deserve the same frequency of care that they had ordered. They don't get excluded from treatment that day. So that's one principle. We've got a therapist assistant making a determination on the fly without the therapist there that the patient should be excluded. And that's perfectly legit. Now, what will I expect from that assistant? They will document what happened. They will coordinate with the therapist in terms of communicating what happened and the therapist will make a determination going forward from there. Perfectly legit, all within practice guidelines. Now, here's another thing. I'm a therapist, okay? I give an assistant a care plan. On that care plan, it says, let's say, Therax, Theract, neuromuscular read. Now, PTs and OTs, you can all relate to those orders because you use those codes. But also, they got 97150 group treatment. So I hand that care plan to my therapist assistant. Now, my therapist assistant, according to the frequency and duration of the orders, will be expected to do Therax, Theract, and neuromuscular read every frequency visit that was ordered. However, group is a mode, and what I've allowed them to do on the care plan is either do group or, in some cases for Part A, concurrent or individual care. They have the option, because that group code's there, to do group or individual. They don't have to do group. It is a mode. It is not an intervention. So by itself. So with that said, the therapist assistant does have some leeway in determining the clinical appropriateness for the group. They're still under my care plan that I developed as the therapist, fully within their legal right. Now, I, as a therapist, have a responsibility to communicate very clearly the purpose and nature of the groups I want my patients to be in. So if I order group, I should be communicating with my assistant why the patient needs to be in group, what I'm wanting them to focus on, and then they operate within those parameters when they do the group. But I certainly want that assistant to be on the fly making decisions about the clinical appropriateness of a group. And I would imagine all of you assistants who watch this video would concur. You are not technicians, and you are not fully dictated to. I give you the parameters to operate within. I give you the goals to work on. You have to stick within those. But then you have some professional judgment that still needs to be applied. And if you don't use your professional judgment, I don't want you treating my patient. And I'm assuming if you have a license as an assistant, you're going to be exercising professional judgment. Anyway, that was my main point, and hopefully that clarified to this therapist that I was communicating with on Facebook. And just a warning, avoid Facebook discussions because sometimes they just go on and on and on. And there's too much opportunity for miscommunication, obviously, with written communication. Sometimes I think it helps to talk it out. Anyway, John Adamson, the Rehab and Documentation Guru. Hoping you have a blessed day. Take care.